Now we're going to move on to Dr. Vineeta Kumar, who is a fellow of the American Society of Transplantation and a professor of medicine and the inaugural holder of the Robert and Contessa Borgia Endowed Professor in Transplant Nephrology at the University of Alabama in Birmingham. She's also director of the Incompatible Solid Organ Transplant Program and plays a key role in UAB's kidney xenotransplantation efforts and their heralded kidney chain through the kidney paired donation program. After completing medical school at MP Shah Medical College in Jamnagar, India, Dr. Kumar trained in internal medicine and served her chief residency at the University of Texas Health Science Center in San Antonio. She then completed a nephrology fellowship at the University of Washington in Seattle and a transplant nephrology fellowship at UAB, where she has been faculty since 2007. Among the awards she's received are the Cobb-Rutsky Award for Clinical Excellence for the past 10 years consecutively, the 2017 Brewer-Heslin Award for Professionalism, the 2018 Dean's Award for Excellence in Teaching, the 2019 Presidential Award for Excellence in Teaching, the 2021 Non-Surgical Faculty Teacher of the Year for the UAB General Surgery Residency Program, and the 2022 Service Excellence from the American Nephrologists of Indian Origin. Dr. Kumar is also the lead facilitator of UAB's Schwartz Rounds for Compassionate Delivery of Care and has multiple national roles, including leading the American Society of Transplantation Education Committee in 2015 and the AST Living Donor Community of Practice in 2020. She's also co-chaired the AST 2021 Living Donor Transplant Consensus Conference and chaired the American Society of Nephrology's COVID-19 Response Team Transplant Subcommittee. She is currently an elected member of the AST Board of Directors, and we're honored to have you join us today, Dr. Kumar, and thank you.
Thank you so much, Jeff. What a legacy you've created at Rogosin Wellness Program. These words of helping our patients get their wings back are definitely going to stay with me. And I've picked up many pearls from Dr. Silverspike and Dr. Pearl and Don's presentation. So I've been charged with talking about expanding the transplant universe and the advances in immunology and xenotransplantation in the past few decades. And I'm really excited to talk about this, and it'll be a tour of force, but let's jump right in. I would like to first start by explaining the terminology allotransplantation versus xeno. Objectives are evident here. Allotransplantation meaning within the same species. So human to human would be allo, and we're going to talk a little bit about the progress there. We'll talk about some advances in immunology, and then touch upon xenotransplantation. Xeno is cross-species. In this case, it happens to be animals to humans. And we'll talk a little bit about why we want to do it and what the need for it is. And I'll do it in these 5 key buckets after we touch on some historical aspects. So if you look at this slide, the thing I want you to take away from this slide is that in the early 1900s, we did a skin and cornea transplant. But it wasn't until 50 years later, in 1954, that the first successful kidney transplant was performed, and it was performed between 2 identical twins. And then if you look back, kidney that paved the way eventually allowed for not just kidney transplant between twins, but actually pancreas transplant, liver transplant, and ultimately heart and lung. And this required significant advances in the surgical technique, but also immunosuppression. So between twins who are chromosome matched, they're identical. There wasn't that much of a question about immunosuppression. It was all about the surgical technique on the donor and recipient side and whether those kidneys removed from one will function in another. And can you live with one kidney, which they had a sense of because of the World War I data where people were shot in the back and lost one kidney. But as they started to move from twins into other siblings and other relationships, immunosuppression became very key. Also, to get better at the surgical techniques, they needed practice, and these immunosuppression and surgical techniques were practiced in animals. And then also, as transplantation became more available and went from the living to deceased realm, we needed to have ethical and medical consensus on some of these brain death related topics. You're going to get a copy of these slides, so I'm not going to go through every one of these time points, but suffice it to say, if in 1945 Call first successfully dialyzed a patient, so point to note that kidney paved the way for, or dialysis and kidney specialists paved the way for transplantation to be able to happen. And about 9 years later, when the first kidney transplant happened, about 15 years after that, the first liver and heart transplant happened successfully. And it wasn't until 1983, which is roughly 40 years ago, that cyclosporin came into being. And with that, let's talk about some innovations in immunology. And if you've ever seen a slide like this and you get overwhelmed, I get overwhelmed all the time. I simplify that and tell myself, if this is the allograft, this is the organ that is going to be injured, and we're talking about kidney because we are all in the kidney space, and I'm a transplant nephrologist. Among all the cells, these cells here, the CD4, CD8 cells, B cells, and NK cells are the ones that are going to really inflict the damage on that allograft, and they inflict the damage on that allograft through various mechanisms, and intervening on the army of these cells and stopping them from happening happens in times preceding this, and different drugs act at different time points. And as we our understanding for immunology expanded, we were then able to also get a sense of needing to use drugs at the time of transplant in a heavy dose called induction therapy, and in various combinations of maintenance therapy, and developed a sense of where our infectious risk within this context. When is it too much? When is it too little? When is it just right? And this fine-tuning of the nuances was very important to continue progress, so that we did not either reduce the risk of rejection at the expense of causing severe infections, or vice versa. And as you can tell here, if 1983 is when the landmark cyclosporin came into being, and 1996 was the next really big one, where mycophenolate mofetil became another landmark drug. Between these two drugs, the face of transplantation changed, where we were able to now transplant people, not just siblings and related, but unrelated, and also organs that had brain death physiology or cardiac death physiology. And one thing to point out is the cyclosporin came into be. It was first found in 1987. It was approved in 1994 by the FDA for liver transplantation, and eventually was extended to kidney transplantation. So in the current day era, most of the immunosuppressive regimens in the US seems to be a combination of tacrolimus, prednisone, and mycophenolate mofetil. Now, along with the progress in immunosuppression that allowed for significantly reduced risk of rejection, we had progress in histocompatibility. So the landscape of histocompatibility, while it's dramatically changed in the ensuing 40 years since 1969, when Dr. Terasaki first sort of brought this to our consciousness, really all the progress that's been made is to provide a reliable estimate of the immunologic risk a transplant recipient has in the context of the potential donor. Is this a risk we can overcome? And we have multiple different tests available along the immunologic journey of a transplant recipient, or sort of transplant candidate, from the pre-transplant stage to transplant and post-transplant. And at each point, we apply these tests in different combinations, just asking a different risk question. Early pre-transplant phase, we say, what's the sensitization where we have a risk of not being able to find a good HLA donor? At transplantation, we're worried about what's the risk of this terrible hyperacute or early acute rejection. And then long-term, with this immunologic testing, we're trying to figure out what is the risk of antibody-mediated rejection. Along with progress in immunology and histocompatibility and immunosuppression, multiple policy changes came into play that allowed transplantation to be what it is today. So 1984, again, roughly 40 years ago, NODA came into being, that united us as a community, as a country, and allowed us to have these common wait lists. And if we go from there to what Dr. Pearl had already presented to us about the Advanced American Kidney Health Initiative in 2019, where along with increasing home dialysis therapies and transplantation, the demand was also the ask of us as a medical community also was to have alternative ways of managing our ESRD patients. So in thinking about NOTA and the organ donation process, and this is pertaining to deceased donors, there's multiple steps involved in this from the time that a person is declared to be either brain dead or had cardiac death and has their circulation resumed. There are multiple steps involved in this process, and a lot happens behind the scenes before transplantation happens. This is the cycle that you can see. And during this time, organs need to be kept going, patients need to be involved, families discussion needs to be happening, and all this matching needs to happen in the background. Important thing to then share is that the OPTN, has a network of 11 regions. These regions are administrative regions. They come together, they discuss policy, they discuss change, give feedback. And this is just a little bit different than areas that share organs, which is sort of the donor service areas, which recently was changed to the nautical mile. And there are some pretty important policy changes that have happened in this past 40 years, that were meant to be things that helped our patients. Empowering our patients while they're in front of us is so essential, and empowering our patients continuously in the background also is what our brilliant policy teams involved in policy changes at every level are doing. And some of the things that impacted our patients positively was getting your wait time back on dialysis. So if you were referred late to transplantation and had spent 10 years on dialysis, your clock initially until 2014 started when you were referred and approved for transplantation. And in 2014, you could now backdate time to when you started dialysis, sort of trying to address this access issue where not all communities and not patients of color are sort of disenfranchised, and how do you make up for it? For the highly sensitized retransplant patients like our Ms. Edwards, CPRA allocation points allowed for them to get a transplant faster. For B recipients that wait the longest on the list, we were now able to send A2 subtype kidneys, so non-A1, so A2, A2B deceased donor kidneys to our B recipients. And more recently, the race-neutral EGFR, which is what went into effect in January of 2023. So these are just a few examples of policy changes, and they just represented a tip of the iceberg of a lot of the things that's going on. So while we are talking about policy change, organ allocation, NOTA, and we talked about the organs that are sort of being available for transplantation, we needed also ways to preserve these organs to minimize ischemic injury and hypothermic injury. There are two phases of damage. The phase of damage where circulation stops before you resume it at the time of patient death, and then the other part is when the organs are removed and preserved, and different organs can withstand different amount of ischemic time. And kidneys, now with the kidneys flying around all over the country trying to get to patients that really need them, the cold ischemia time in some of these kidneys can be up to 36 hours. So we require really important cold storage and machine perfusion technologies. And this has been another pretty fascinating innovation in transplantation. And so with all of this to say, this past in 2021 was our sort of the best year where more than 40,000 life-saving transplants happened, about half of which were kidney transplantations and the rest being other solid organ transplants. So fantastic, good work, but is this enough? And this is what brings me to talk a little bit about xenotransplantation. What are the facts in 2023? If the gap between supply and demand is vast and it just sort of increases more and more, this line here tells you the demand, and this line here is telling you how much we are able to do. So people waiting for transplant versus number of transplants, as you can see, this line sort of looks pretty plateaued versus this line continues to increase. And so annually, if there are about 80 to 90,000 patients waiting for a kidney transplant, 89,000, about 25,000 patients actually receive a transplant. And the sad part is more patients die waiting for a transplant than ever getting a kidney transplant. And then they just reflect a fraction of the patients that are actually eligible. 1 in 7 end-stage kidney disease patients actually make it to the waiting list. So most are not fortunate to make it to the waiting list. And of the ones that do, we are not able to transplant all of them. So we need a radical solution, a solution that was thought to be impossible, and the xenotransplantation solution. And how impossible, or I am possible, is the solution now, as Dr. Martin Rothblatt talks about. And here's the timeline of advances in the xenotransplantation that's happened. 1985, again, roughly 4 decades ago, is when we established the pig to non-human primate, the baboon model to study xenotransplantation. And they tried to put pig organs into non-human primates and had rejection episodes. And what were some breakthrough things that happened? First was the GAL xenoantigen is what we found. And what GAL xenoantigen is that all non-human primates have this, but humans in evolutionary biology, we lost this antigen. So now we see this antigen in pigs as a foreign antigen, and we attack it, and that's what was causing the severe rejections that were being seen. And fast forward now to the CRISPR-Cas technique that came into being that allowed us to knock out some of these antigens that humans were seeing, and brought about the concept that, wait, don't give a lot of immunosuppression to the recipient, and you give so much immunosuppression that the recipient can survive the immunosuppression. Just change the donor, make the donor more human-like, knock out all the things that are foreign in the human, in the pig kidney, and add protective things so that you can now take that organ and put it into a human. So humanize the pig organ was the entire thrust. And in the interest of time, I won't go through the actual somatic cell transfer, but this is a beautiful slide. And if you review it, you can see we can take a pig mom, remove the oocytes, remove the nucleus, put in the nucleus we wanted to, and then we have birth of clone piglets that we can use. And this slide illustrates that when we tried to do these clone piglets into non-human primates, if we use this heavy-duty immunosuppression, it worked just fine. But if we didn't use it, then those grafts did not last long. And the problem with this is that this is not the standard immunosuppression. I just showed you the induction and the maintenance therapies, and anti-CD40 monoclonal antibodies, not what we use. And more importantly, pig to non-human primate is still a model of incompatibility because the pigs made more human-like. We need to study this in humans. This is where the Parsons model is something that we sort of were one of the first ones to think about, but actually do this experiment in September of 2021, where it's a human brain death decedent model. And Mr. Parsons was the gentleman who passed, and his family was the one that consented for this study because they thought he would have wanted to contribute to science. And we were able to use this 10-gene pig knockout into Mr. Parsons after his native kidneys were removed, and we're able to show that test a lot of hypotheses. And we were able to publish this in December of 2021. And essentially the critical questions answered were that we did not see hyperacute rejection. We had identified a preclinical compatibility cross-match. We were able to do the surgery without having the human blood pressures affect the pig kidney, and the anastomosis held up. And we're not able to see pig cells or pathogens in the recipient blood. Again, this was only for 77 hours. and that we could do it safely under human-like conditions. And so the last bit of the slide then talks about where do we go next? Do we need more non-human primate studies? Do we need more decedent studies? And what is the progress towards clinical trials? There's general agreement that kidney should be the organ leading. So again, the kidney failure leads the charge. And the important question then becomes, what do patients have to say about this? And so I'd just like to finish with this patient engagement slide. Ms. Dawn just talked to us about helping our patients find their wings. And that sort of so informs what my philosophies in patient care. I want to enter every room. I try to enter every encounter with the patient with the notion that I'm here to serve you. I exist because you are there, and help me help you get what we need to get for you. So patients as partners, connecting with our patients in their personhood and beyond their disease, and more importantly, not confusing education with communication. Communication is when we give them slides, we give them information, kind of put them in information overload. And what patients have told me, have told us, is meet me where I am. Find out how much I know and take me along on that journey with you. Knowledge is power, we learned, and then do it continuously over time. Even the most educated, evolved patient, just like an educated, evolved medical provider, we can all continue to learn and refine. So with that, I will stop and just sort of add the future is bright, and I'm delighted to be part of this symposium and the amazing work Rogosin Wellness Program is doing. Thank you.
Thank you so much, Dr. Kumar. That was a terrific talk and very exciting look at our future.